Uh, Thank you so much for being here, for asking me, Caitlin. I'm delighted. This is the research that I completed as a part of my dissertation. So you'll see throughout maybe a leftover aim in there somewhere. And so I appreciate feedback. One of the aims has been published as a journal article, but actually, because of the time allotted for today, I'm going to try and also present some of the work for the second aim, which is not yet published, but hopefully soon. So, again, I'm Julia Reddy. I am 2025 grad from the University of North Carolina School of Public Health doctoral program in maternal and child health. I did a lot of my research with a faculty member from the School of Social Work there, and that is the data that I used for this project today. I'm looking forward to questions and discussion afterwards, so please put them in the chat or hold on to them, and I will save time for that at the end. Just a note, this work was funded by a F31 fellowship from the National Institute on Drug Abuse. The content is solely that of the authors and does not represent the views of the National Institutes of Health. So here's where we're headed today. I'll introduce the topic very briefly. We'll move on to the methods and results of the two research projects, and then we'll finish up with some limitations and implications. I want to start just by acknowledging the erasure of trans people in healthcare and research. Research is lacking on gender diversity in perinatal health, and many identities are omitted or elided because of mismeasurement and insufficient data disaggregation. Simultaneously, many perinatal risks and challenges are etiologically linked to discrimination and oppression that is rooted both in biological sex through sexism and gender through misogyny. Those with substance-exposed pregnancies encounter uniquely gendered stigma from discrimination regarding good mothering, which can make it harder for them to embody the mother identity. In order to preserve that identity and to articulate both the gendered and sex-based oppression that affects the treatment and health outcomes of individuals who use substances prenatally, I will use woman and mother interchangeably with person, people, and individual. For our analyses, women and mother and maternal will be used as this best represents the structure of the administrative data I used. Additionally, the use of person-centered language is important to remembering the humanity of the individuals that we study. So I will talk about people who use substances and infants who are exposed prenatally to substance use. So I will go quickly because I know that you are all experts in this already. In the United States, the gender gap between men and women who use substances has been steadily narrowing over the past 4 decades, with women increasingly reporting alcohol and other drug use. There are both sex and gender-specific characteristics of substance use, including a more rapid progression from use to use disorder or addiction among women. Women also have unique antecedents and corollaries of substance use disorder, including trauma, mental health problems, and exposure to violence. The capacity for pregnancy and higher likelihood of caretaking responsibilities affect how substance use manifests among women, how it's perceived by society, and how it is treated or not in existing systems of care. Disparities in screening, testing, and reporting for prenatal substance use have been documented across racial, economic, and substance type categories. The scope of prenatal substance use is hard to define because of variations in definitions and measurement strategies. So here you'll see self-report measures suggest 1 in 7 women use drugs or alcohol during pregnancy. Study from 2018 that combined self-report with tox testing found roughly 1 in 4 pregnant people use substances. However, substance use is not typically documented on the birth record in diagnostic codes from the delivery hospitalization, so those capture just a fraction of use. This matters because during pregnancy, despite consistent public health messaging, substance use often indicates some form of use disorder. And even in cases where an individual is able to stop use during pregnancy, returns to use postpartum are common. While prenatal substance use may have teratogenic effects on fetal development, postpartum or parental substance use can interfere with parenting capacity and may put infants and children at risk of abuse and neglect. So the primary established response to prenatal substance use is situated in child protection systems in the United States, and it is dictated by layers of bureaucracy. Very briefly, a 2003 amendment to the Child Abuse Prevention and Treatment Act required states to address the needs of infants born with and identified as being affected by prenatal substance exposure by requiring healthcare providers to notify child protection systems of infants with prenatal substance exposure, which I will refer to as IPSE, and to develop plans of safe care for affected infants. In 2016, another reauthorization of CAPTA required states to report IPSE numbers annually to the federal government, as well as numbers of plans of safe care that were created and numbers of families that received service referrals prior to hospital discharge. The 2003 CAPTA amendment explicitly stated that IPSE notification should not be construed to establish a definition under federal law of what constitutes child abuse. Still, there is a lot of latitude for states to define the statute. They can define what affected by substance exposure means. They have to determine the process for notification of affected births, and they're on the hook to invent a system to develop and coordinate plans of safe care, to establish a service system to these families, and ideally prevent family rupture as well as child maltreatment. So here you can see a timeline that a number of states responded to the 2003 CAPTA legislation by passing mandatory reporting policies that require universal child protection reporting for all substance-exposed births. By 2018, roughly half of U.S. states had some form of mandatory reporting law related to IPSE in effect. Mandatory reporting, however, does not guarantee compliance with CAPTA. A 2018 analysis found that only 2 states were fully compliant with federal law. Additionally, mandatory reporting has been shown to negatively affect patient-provider relationships, deter women from seeking care, and make it harder to engage families in services. So instead, there have been strong calls for public health responses to substance-affected births, responses that feature non-punitive mechanisms for data collection, voluntary service referrals, and risk-based child protection reporting. So the state policy context for this research is California, which is a large, racially diverse state that has since year 2000 had a law in the California Penal Code that states a positive toxicology test at delivery is not a sufficient basis for a child maltreatment allegation. See, now I'm going to read the chat, and I shouldn't because I will save it, but thank you for putting questions in. So they require an assessment of needs be conducted by the delivering hospital to determine whether the infant can be safely discharged without CPS intervention. So this is an example of a discretionary reporting policy. Researchers, clinicians, advocates claim that discretionary reporting policies protect against unnecessary CPS involvement, but there's not a lot of research examining their functionality in single state contexts. So in 2017, California's Department of Social Services released an all-county letter defining IPSE as an infant where substance exposure is indicated at birth and subsequent assessment identifies indicators of risk that may affect the infant's health and safety. So this limits that mandatory plan of safe care creation and child protection reporting only to those IPSE with additional care and protection concerns. So this does limit CPS involvement at the discretion of the medical provider, but it also exempts a portion of substance-exposed births from mandatory safety planning and service referrals. This unique policy context allows our study to examine the performance of a discretionary reporting policy that is inextricably linked to preventive initiatives. So just quickly, the second reason for our California setting is just this availability of this fantastic population-based longitudinal cohort data that's available through the Children's Data Network. The CDN partners closely with California public agencies, foundations, academic institutions, leveraging large data sets that are linked at the individual level for research and programmatic agendas that aim to improve family health and well-being. So overall, the objective of this work was to better understand the performance of a discretionary reporting policy by examining consistency of reporting decisions and longitudinal patterns of CPS involvement. We sought to evaluate whether discretionary reporting operationally achieves its goal of selectively involving CPS when required to protect children from immediate harm. In our first project, we analyzed patterns of substance use diagnosing and CPS reporting through an intersectional lens to identify reporting variance by individual and hospital level demographics. And in project 2, we measured CPS intervention, 2 different outcomes, forms of reports for maltreatment harm and any substantiated reports over 5 years among a group of infants who had no hospital CPS report according to their documented substance exposure status. The theoretical grounding for this work is rooted first in intersectionality, so populations who live at the junctures of oppressions, for instance, racism, sexism, biases against addiction, and subjugation of pregnancy, experience each ripple of discrimination and disadvantage as well as a compounded effect of dwelling at multiple margins. We use this theory to frame our research questions and to understand our findings. We also rely on the theory of street-level bureaucracy, which asserts that law or policy cannot be understood except by analyzing its performance on the ground in individual institutions and among individual providers or provider teams. In our context, nested within federal law, state law, institutions like birth hospitals have their own policies and common practices, and additionally, individual providers act as agents of the state to reinforce or undermine law, policy, and established practice. This theoretical lens has confirmed the importance of our examination of our outcomes within a single state policy context. Administrative data from 3 sources were combined by non-research analytic staff at the Children's Data Network before being de-identified and made available for this analysis. We used hospital maternal discharge records from the California Department of Healthcare Access and Information, vital statistical birth records from the California Department of Public Health, and child protection system records from the California Department of Social Services. The study included 423,363 births that occurred in California between January 1st, December 31st, 2018, who had a birth record that successfully linked to a hospital discharge record related to a live birth event. So that represents a 93% match rate. And this figure displays how we derived each sample from the birth cohort, which we will go through for each research project individually. The analytic strategy for our first project, we started by thinking about the real-world context of the analysis. So compared to research studies and self-report surveys, you'll remember that diagnostic documentation captures just a fraction of substance exposure without a standard benchmark of selectivity. Given our theory of street-level bureaucracy, it's reasonable to expect that providers do an imprecise job of deciding who should be screened and recorded as having substance exposure and who among those receives a report postnatally. Given our understanding of intersectionality, we imagine an effect of bias both at the institutional and provider-patient levels on the outcome measures. So in response, analytically, we look at observable predictors of reporting among a group with documented exposure. So specifically, we asked what births in California in 2018 had diagnostic evidence of prenatal substance exposure, and among those with diagnoses, who were referred to CPS in the first 14 days of life. We also asked if there were associations among individual-level demographic categorizations and hospital-level characteristics and hospital CPS reporting. Our sample for this analysis was restricted to the 3 categories of race and ethnicity that had the highest prevalence of substance use-related diagnoses on the birth record in order to have sufficient sample sizes for multivariable hierarchical modeling. So those were Black non-Hispanic, white non-Hispanic, and U.S.-born Hispanic mothers, and those categories were derived from self-report data taken from the birth certificate. We also restricted the comparative analyses, only to those births that had diagnostic information on the maternal hospital record, which resulted in a sample of 6,756 births. The outcome variable for this analysis was any child protection report within 14 days of birth, and we specified individual level predictors, including low birth weight, the timing of prenatal care, parity, establishment of paternity, maternal race and ethnicity, birth payment type, and whether cannabis use was the only specific substance listed on the diagnostic record. We specified 2 variables at the hospital level. One, whether more than 50% of 2018 births at that hospital were to non-Hispanic white mothers, or what we called majority white hospital, and whether more than 50% of births that year were to publicly insured patients, majority public hospital. So quantitatively, the outcome of child protection reporting relies on this unobserved estimation of risk, this decision to report on the part of the provider or the provider team. We tried to predict this by estimating the effect of various observable perceptual inputs measured by maternal demographic characteristics and this decision to report. However, each individual in the dataset is giving birth in a California hospital or birthing center. Each provider or provider team who's deciding whether or not to report works in that institution. So it's reasonable to expect that the hospital environment has an effect on the outcome. For instance, if a hospital instituted a universal reporting policy of its own. So we clustered our associations by hospital to capture the variance between and within hospitals, and we also included hospital level variables that may affect reporting rates. This is too in the weeds, I think, but we attempted a conditional random coefficients model that would have allowed random slope coefficients by hospital, as well as a model that would have allowed the level 2 covariates to adjust the covariates of the coefficients of the level 1 covariates, but those models did not converge. So we opted to include interaction terms to our conditional random intercept model. So we allowed moderation by the individual level, race, and ethnicity variables on the association between the hospital level, race, and ethnicity and the outcome, and the same for insurance type, which we can dive into in questions if there are any. Okay, so what were our results? Out of the 6,756 births that had diagnostic documentation of substance exposure, which represented 2.6% of the full both birth cohort of match birth of those 3 racial and ethnic categories, just over 45%, or 3,070, were reported to CPS within 14 days of delivery. So this is not an exact measure of infant discharge, but we're assuming that 14 days of delivery represents approximate hospital reporting decisions. So notably, more than 45% of births with documented substance exposure had no substance other than cannabis indicated on the maternal record, and of these births, just over a quarter were reported to CPS in the first 2 weeks. Substance type differed by racial category, with 5.6% of births to non-Hispanic Black mothers having a substance use diagnosis, and nearly 3/4 of those, including cannabis, almost 65%, including no other specific substance other than cannabis. So this compared to non-Hispanic white mothers, 2.5% had any diagnosis. 40% of those referred only to cannabis. Analytically, we specified an unconditional random intercept model, meaning we included only the outcome variable of CPS reporting and the cluster variable of the birth hospital, and from that model, we derived the interclass coefficient, which explains the amount of variance that is between clusters, and our ICC of 24% is considered sufficiently high to justify the use of multilevel modeling. In our fully adjusted conditional random intercept model with interaction terms, we found an association between child protection reporting and public health insurance, and between child protection reporting and delivering in a hospital that served majority publicly insured maternal patients. Predicted probabilities show the differential association between hospital-level patient demographics and child protection reporting for individual racial and economic categories. So here, for white, which is the green line, and Hispanic, which is the blue line, mothers, the predicted probability of reporting in hospital with, here, minority white, fewer than 50% of births occurring to white patients, tended higher than in a majority white hospital. This decrease in prevalence of reporting or probability of reporting was not observed among Black mothers, whose likelihood of reporting was not significantly different in a minority or a majority white hospital. For those with private insurance, which is the blue line here, delivering in a minority public hospital had a lower predicted probability of reporting. So this is 24% relative to a majority white hospital, 42%. For those with public insurance, however, the predicted probability of reporting was not different in a majority versus a minority public hospital. Interestingly, within hospitals where fewer than half of the births were covered by public insurance, individuals with public insurance were nearly twice as likely to be reported than births covered by private insurance. Okay, time check. We're doing all right? Ready for AIM 2? Okay. So while the first project examined which dyads among those with diagnosed substance exposure were reported during the hospital stay, our second project was interested in those dyads that were discharged from the hospital without a report. So in project 1, we wanted to see whether discretionary reporting happened equitably. Now we're concerned with whether it happens effectively. Specifically, we asked who was not reported in the first 14 days of life, and among those who were not reported, were children with an indication of substance exposure more or less likely to be the subject of a CPS report for maltreatment harm or a substantiated CPS report over a 5-year period compared to those without substance exposure documentation. So again, we weren't able to identify the date of infant discharge from our data, so we restricted our analytic sample to be reasonably confident that the dyad was discharged home within 14 days by eliminating very preterm and very low birth weight infants. We dropped multiple births so that we could analyze CPS interactions at the family level, and we included only first births in 2018 to limit bias that may be introduced from a maternal history with CPS or prior custody losses. So this left us with a sample of 160,725 births. Our primary exposure was documentation on the maternal hospital discharge record of prenatal substance use. And of those with any diagnosis, more than half included a diagnostic code that mentioned no specific substance other than cannabis. So we wanted to determine whether longitudinal risk of CPS involvement was associated with substance type. Therefore, we included cannabis only and other or multiple substances as secondary exposure variables. Exposure variables were coded dichotomously, and adjusted models included individual level covariates, including maternal race, ethnicity, birth payment type, establishment of paternity, maternal age and education at the time of delivery. 2 outcome variables were specified. First, 5-year incidence of reporting for maltreatment harm. And we defined that as an allegation of physical abuse, sexual exploitation, severe neglect, or caregiver incapacitation. So we are not including allegations of general neglect, emotional abuse, or no allegations. Those were coded as negative. In California, the allegation of caregiver incapacitation is used often in situations of significant parental inability to care for the child, and it often indicates situations of parental substance use causing child harm or imminent risk of harm. The second outcome was an allegation that was investigated and substantiated, and for that, any allegation type was included. For both outcomes, we also captured the timing of the first qualifying referral for survival models. So we're very clear here that our exposure and our outcome variables are observable indicators mediated through system performance. So our measure of substance exposure is mediated through the process of identification, and our outcome measure is CPS involvement, which is not necessarily or exhaustively an experience of child maltreatment. We're focused on the system performance rather than the actual incidence of child maltreatment or substance use during pregnancy. Okay, so I'm going to speed up a little bit. I think we'll get into that. The descriptive results, again, 163,071 first singleton births in 2018. Less than 2% were identified as having substance exposure. And of those in the first 14 days, of those who were not reported in the first 14 days, in the first 14 days, sorry about that. So this is the full sample, and then we'll reduce down to those who were not reported in the first 2 weeks. So this is the full sample. Less than 20% with cannabis listed on the maternal discharge record were reported in the first 14 days, compared to nearly half of those with other or multiple substances on the discharge record, and less than 1% of those without documented substance exposure. So these are these early neonatal reports. And then we drilled down to our analytic sample, which was 160,725 unreported births. 1.1% had documented substance exposure. More Black mothers were diagnosed with substance use compared to all other racial and ethnic categorizations, and over 80% of those were for no specific substance other than cannabis. Among all children who were not reported in the first 14 days, children of Black mothers were the most likely to be the subject of a CPS report for maltreatment harm and to have a substantiated CPS report. Among those with either a maltreatment harm or a substantiated report outcome, children of multiracial mothers were the most likely to have documented substance use. In fully adjusted Poisson regression models, births with documented substance exposure were 2.2 times as likely to be reported for maltreatment harm compared to those with no documented exposure. And when we disaggregated by type of substance exposure, both documented cannabis-only exposure and exposure to other or multiple substances are associated with a report of maltreatment harm compared with births with no recorded exposure. So this can also be understood as a risk difference of nearly 5 percentage points, with higher risk in 5-year maltreatment harm reporting for births with documented substance exposure, even if that substance was not listed as anything but cannabis. For the outcome of substantiated maltreatment report, adjusted risk ratios also found higher risk of substantiation of a maltreatment report among those with any substance exposure, whether it was cannabis or other or multiple substances. The 5-year risk difference was about 3 percentage points higher for infants with documented exposure compared to those without. The risk increased from about 2.5% to 5.5%. So that's notable, I think, is overall the prevalence of child protection reporting over those 5 years was below 14%. And the adjusted risk difference between exposed and unexposed infants was less than 5 percentage points. So that kind of puts this in perspective. These are kind of over time. If you're on the left, you're looking at reports of maltreatment harm, and you see actually those with exposure to cannabis had more reports of maltreatment harm over the 5 years than either those exposed to other multiple substances and those exposed to no substances. And on the right is any substantiated report. Very quickly, there were 100 kids in our sample who had an out-of-home placement prior to their referral alleging maltreatment harm. We dropped them, reran everything, and the sensitivity analysis did not meaningfully change our coefficients. So some limitations. Or should we pause for questions?
No, you're good. You can continue.
Okay, great. So we identified our exposure groups by diagnostic documentation in the maternal hospital record. So selection into our study or selection into our exposure group relies on provider screening, testing, and documentation behaviors, and all of those are affected both by jurisdictional and institutional policies as well as norms of provider behavior and discretion. Secondly, the 14-day reporting cutoff rather than the actual infant discharge date means that children may have been reported following discharge, but in those first 2 weeks, or after 2 weeks, but still during their hospital stay. Thirdly, just want to note that our inclusion of race and ethnicity categorizations are explicitly an attempt to adjust for the effect of racial discrimination in healthcare and social welfare settings, as well as proven associations between structural racism and situational circumstances associated with both substance use and reports for child maltreatment. So we control for the effect of race and ethnicity in our model, but we're really emphasizing associations with modifiable variables. In our first project, we lacked data on other potentially important individual, hospital, and provider level variables, although our use of hospital as a clustering variable attempted to capture unobserved differences, at least at the institutional level. Also, the dichotomization of the hospital level variables resulted in information loss. For Project 2, omitted variables included more nuanced measurements of economic positioning and other factors such as family violence that might have explained some of the association we found between substance exposure and later child protection involvement. Additionally, we were unable to determine whether children from our cohort died or moved out of California during follow-up, and this out-migration might have occurred disproportionately by exposure status contributing bias to our observed outcomes. Further, other interactions a family might have had with child protection services that did not qualify as one of our measured outcomes might have affected their likelihood of later experiencing a qualifying interaction, although we did run some sensitivity analyses to attempt to account for that bias. So, implications. There is this ongoing national struggle, conversation, work to understand how to identify infants with prenatal substance exposure and smartly determine which families need child protection intervention and which need a community-based response. Our results suggest that discretionary reporting, which is often lauded as a better alternative to universal reporting, is inconsistent across providers and hospitals. And that indicates the need for better processes for identification, training, and reporting equity. A particular point that this work has to contend with, in my mind, is the correct response to cannabis exposure. Cannabis is increasingly being seen as innocuous. More pregnant women are disclosing use. Cannabis use diagnoses in this project were found to be applied disproportionately to maternal records of non-Hispanic Black women, potentially because of biases in testing. However, cannabis is a proven teratogen, and our results demonstrated a persistent association between diagnosed cannabis exposure and later child protection involvement. Our results help hopefully to inform efforts to determining the position of cannabis in programs and policies defining substance exposure and dictating an appropriate response. This project also demonstrates that substance-exposed infants who are discharged from the hospital do carry an elevated risk of CPS involvement, although there is some question about the importance of the magnitude of that risk. We know substance use is a chronic, relapsing behavioral health condition that affects parenting behaviors and the ability to maintain a safe environment for children. Even for folks who stop using during pregnancy, births that might not qualify as substance exposed or be identified by providers might return to use postpartum. And women with substance use disorders face many barriers to treatment. You all know all of those, and I will skip that part. Racism and a lack of appropriate care for women with trauma and co-occurring conditions compounds these barriers to treatment services. And the Plan of Safe Care process was designed to try and connect families to an array of infant developmental and parental behavioral health services prior to hospital discharge, but without a robust system of care. Discretionary policies' promise of avoiding CPS contact may just be a temporary reprieve. Identifying a workforce to assist families in the creation of plans of safe care and to provide warm referrals to community-based services might ameliorate the outcomes we observed. So, in conclusion, up to a quarter of births in the U.S. are affected to some degree by prenatal drug and alcohol use. Exposure has a lasting effect on child health and development, and it might affect parenting capacity and is associated with child neglect abuse and abuse fatalities. However, child protection systems are seen by many families as punitive, coercive, and a surveilling force. The primary source of supportive services for this population is ill-placed within an agency that is feared and avoided by many parents. It's vital to institute a public health-oriented response to prenatal substance use that both addresses familial need and protects children from harm. The CAPTA authorization intended this, though the statute is vague and states have struggled to respond. Rigorous epidemiologic research is needed to examine the effect of various policy approaches on family welfare. This work attempted to answer this need by evaluating key aspects of a discretionary reporting policy. Our results hopefully contribute information about biases in reporting and the need for additional supports among non-reported families. And I just want to take a moment to thank the California state agencies that are courageous enough to share and publish their data in hopes of improving system functioning. I will stop sharing so that we can have a discussion, but I will pull slides back up if folks have specific questions.
Wonderful. Thank you so much, Julia. That was great to be able to see all the great work you did. I know it's hard to distill such a big project down into a shorter presentation, so we appreciate that too. Um, we've had some questions in the chat, and please, everyone else, if you have any more questions, please feel free to put them in there. The latter question you actually started to answer, but I wanted to open it up if you wanted to elaborate any more. And it was looking at your analyses of the only cannabis versus other substance exposed infants. And so you can see the question in the chat was the last one. So I wanted to ask you if there was anything interesting that you noticed that you went over your results between the two groups, but I just wanted to give you space if you wanted to re-emphasize any of those results, potentially the racial difference that you noted, and any more public impact that we can take forward, knowing that a lot of people in this call also are clinicians and also working in the clinical space of trying to move things forward at their institution level, which I know was a big focus of your talk today.
Sure. Yeah. And it's a good question. And I'm not going to remember his name, but there was a paper that came out last year showing that babies exposed only to cannabis did not have meaningfully different interactions with CPS in a discretionary reporting environment than those with no substance exposure. And we found the opposite of that. We found something different than that. And I think that that was an important point to kind of add to that dialogue. It all depends on how you measure it. The first answer of why it was pulled out separately was because no other substance in our sample reached that level of prevalence alone. So 45% of substance exposed births had nothing but cannabis. So it was not pulling out because I think cannabis is categorically different in terms of an exposure, but the prevalence in our sample was so striking, it was almost half of the group, that I wanted to make sure I wasn't attributing an association to all substance exposure that actually was being driven by one or the other half of our sample. So methodologically, I think that's why I pulled them apart. And then I do think we saw a little bit of difference, particularly in substantiated reports, that justifies that they were interacting slightly differently over time in terms of child protection interactions. And also the fact that of babies exposed to multiple or other substances, almost half of them were being reported within that first 14-day window. So that, I think, is also potentially differential bias. Once you remove that half, the remaining half might be less likely to have ongoing CPS contact because of the nature of that family situation that didn't justify a neonatal report.
I just want to reflect on the fact that your decision for the analyses, like you just discussed, was data driven. So you really did see differences between these two groups in your own data, and that drove your analytic plan. And I think that's good for us to know that going forward, if we're working on anything related to the space at our own institutions, that it is a substantiated that it is appropriate to look at those two groups separately, most likely based on not just our preconceived ideas of cannabis versus other substances, in addition to the data itself at an institution level.
One thing that I want to just put out there is I think when I'm thinking about reporting for prenatal substance exposure, you're thinking kind of, okay, why are you reporting? Are you reporting because you think that the teratogenic effect of exposure merits, intensive kind of surveillance or developmental service supervision? And then you ask if CPS is the right place to receive those services. Or are you doing it because you think the parental use is going to translate into an unsafe postpartum environment? And so I do think in that respect, there is some discussion about whether cannabis use impacts parental capacity to the same extent as something like fentanyl use. I'm not sure. I think we do see increasing ingestions among young children and toddlers of cannabis products that are incredibly lethal. So I'm not arguing for that, but I am thinking about reporting having to do more with that kind of postpartum environment potentially. Naming associations of developmental outcomes at teratogen. Can you explain that? I'd love to hear that out loud so I make sure I'm not saying something incorrect.
Sure, sure. And I apologize. I don't want to be a nudge, and I do not have any of the talent and skills at data analysis and statistics that you do. I'm just a regular doctor. But we talk to moms with substance use problems every day, and they're very concerned about potential teratogenic effects. If the studies that I've, as best as I could, understood, demonstrates that substance use is associated with decreased developmental outcomes, but almost always compared to all comers. Very rarely are those studies comparing to people who are economically the same, racially the same, domestic violence the same, other ACEs the same. And the studies that I've read, that as you try to get more similar populations, those developmental outcomes become less and less and less. Until often you'll see a study where they'll have 20 developmental data points because of subscales and difference of boys and girls, and one will pop positive with a p-value, and they'll report it as a positive test of developmental outcomes, right? So I think it's really questionable to what extent substances are teratogens, with the exception of alcohol, in the way that alcohol is a teratogen, thalidomide is a teratogen, and to what extent it's a marker of other social and developmental and genetic risk factors that families face. And again, this is really important, because to expose your child to teratogen is to be a villain, and our mothers are villainized, and that's a label that people
agree.
carry. And in fact, because access to developmental services are labeled as being due to the teratogenic effect of substance exposure that the mother did to the baby, most of our mothers feel very uncomfortable in the spaces where they could get developmental supports for their babies, because they're attached to this idea that you did this to the baby. And only really adoptive parents, at least in our community, feel comfortable seeking those services, and birth parents don't feel welcome there.
I agree with that.
Yeah, I agree with that too. And I think you got to that, Julia, that, there are these two perspectives or frameworks of when we're talking about reporting, the topic of your presentation. And it's the latter that we all, right, should be focusing on, like what you said, right? Is the reporting appropriate when we're moving into the postpartum period? But I agree, sometimes it does become somewhat synonymous with the concern for harm during the prenatal period. But that is not the framework, right, that you were working from, nor the framework that I believe even Child Protective Services would say that they're working from in the primary framework, if I'm understanding the discussion correctly.
And I think the third one is to try and punish or deter prenatal substance. I think that this universal reporting can be, used or have the effect of feeling like it's, punishing the parent, trying to fix the broken child. And really, yes, I agree that ideally it is assessing the safety of that home for infant child safety and responding to that.
Yes, and I think it's good to make sure that we're making that clear when we're having conversations with people on different multidisciplinary teams, to make sure that everyone's on the same page of the end goal, right? Where are we? If we're trying to change, institutional policies, et cetera, let's all make sure first that we're all on the same page about what the end goal is and the perspective that we're working from. Because I have found that potentially, like Jim was bringing up, I'll be in conversations halfway through and be like, hold up, I don't know if we're all on the same page about what the big picture is that we're all working towards. When I thought we were, but I didn't do that check at the beginning like I should have, in the group setting. So I think that's a good framework potentially to work from if we are in those spaces when we're having these big teams come together to have conversations. We all can be empowered to take the lead to make sure that ask the group first, what perspective are we working from? And those two scenarios that you laid out very well, Julia, I think can give us a perspective to work from to have those conversations.
At the same time, I am not coming down. I am absolutely not a neuroscientist, but I am not putting my money in the fact that cannabis is not teratogenic. And also I've seen really compelling presentations showing kind of the structural changes in infants that were exposed prenatally to nicotine and affecting their risk of SUIDs. So I'm not saying that. I am saying that it's incredibly complex, and I'm very interested in research of child developmental outcomes, because ultimately that is what matters, not policing adult behavior, but making sure that we are putting the services in place, ideally in a public health system, to support child well-being, whether that is, if the effects of environmental toxins and poverty are more severely catastrophic to infant developmental health or to child developmental health than, a prenatal drug exposure, I'm absolutely game. But I think that THC products and cannabis are incredibly powerful formulas that affect a lot of parts of the brain. And I can't imagine that they don't affect fetal brain development. But of course, that is not my area of expertise. So,
yeah, and I just want to make sure we're not steering in that conversation today, because that is not the intended topic about. But I will call out and that we did have a prior journal club on that topic. So if you want to talk
I'll
more
watch
about
the YouTube.
If anyone wants to talk
Great.
more, I put the link to the YouTube station in the chat. It was one of our earlier ones with Dr. Sarah Roberts, who does a lot of work in that space. So
Great.
if anyone wants to learn more about some of the cutting edge evidence that's coming out, like literally every day, I feel like on the topic of cannabis exposure prenatally, I would encourage you to please go back to one of our prior journal clubs. Barbara, you have your hand up, so I'll let you speak with your question.
You're muted, though.
Muted.
Okay, what about now?
Then it went
I
away.
had you for a second, but you went away.
Okay, I'm back. I have two mute buttons, so I didn't want to create feedback. Okay, two questions. One is just a sort of detailed question. I think in part two, in the sort of very important work with regards to sort of the intersection with race, one question I'm just interested in is confirming or clarifying, is it caregiver race or infant race? And then also sort of like, which administrative source of race did you sort of go to as being, the source of race, recognizing that, sort of the social construct of race can be sort of characterized and reported and conceptualized in many different ways across different contexts. And then I have another question, but
I went through it very quickly. So we only had access to the maternal discharge record from the hospital. So we used that to code race. It's in California, there's a self-report worksheet, and we used primary race and did not incorporate secondary racial or ethnic categorizations that might also have been checked. So there was some loss of information there. And we were clear throughout to talk about maternal race.
Perfect. Thank you so much. And then for one additional sort of question or percolation is particularly in sort of thinking to the follow-up space, right? Like I think when I think about sort of perinatal, sort of identification of substance use and, sort of clarifying the connection to child welfare, it absolutely is a thing that we sort of hold in the medical space. Whereas once a child is discharged, referral, sort of infants are interacting with many different referral sources. And so I was also curious to sort of hear more about sort of where were those postnatal or sort of after discharge report or referrals initiating from in terms of sort of, sort of what are additional points of contact, recognizing that, there are many, and sort of physicians or medical providers are not the most common source of report, in nationally substantiated data.
It's a really good question, and I think we didn't look at reporter source for those postnatal up to 5 years. We did look at up to 5 years because that period prior to school interactions is a time of kind of lower visibility of some children who are not in daycare or settings or something like that. And so we wanted to see kind of what's happening during this sort of key vulnerable stage. But it's a good question about where those reports are coming from. The reason that we limited our outcomes to reports of maltreatment, harm, or substantiated reports was to try and get rid of some of that noise, which can be highly susceptible to bias and discrimination. So reports for general neglect, for instance, are strongly associated with particularly economic and geographic biases. So thank you. I'm falling behind in the chat here.
No, it's okay. That's my job.
Okay.
I'll ask one final question from a prior question that was asked. Kind of just thinking about implications going forward. A common topic that comes up a lot in these journal clubs is about screening, right? Screening for substance use during pregnancy and what is, how we define screening, right, et cetera, how different institutions might define what their screening is in different ways. And just wanted to get your take, Julia, on impacts from the data that you have on how screening practices at an institution level are potentially intersecting with outcomes related to reporting. And if you have any comments, or I don't know if you had anything in your data about that, but any comments on that as we close.
I wish I had data about that. Davita did a really cool, Davita Schiff from MGH did a really cool national survey of providers across the country about their screening practices and use of consent and before toxicology testing, reasons for initiating tox testing, et cetera. And I think once that comes out, we will have some good baseline numbers for how folks are, at least in their institutions, perceiving policies and practices around screening and identification. But I'm looking now at this comment, and I think that it's a really good point. I think that depending on the state and hospital policy, if there is a discretionary reporting policy in place, then an opportunity to do screening at the first prenatal contact, if it's, before delivery, creates this chance to engage with that family, boost natural supports, connect to services as needed, and get them in a place where you feel like after delivery they can safely discharge with that infant. I think that's the goal, and I think for a lot of people, having that guillotine of, well, everyone's getting reported to child protection creates this reticence to disclose and to build kind of a positive rapport during pregnancy. And ultimately, I think there's some evidence making the outcome at delivery worse than it could be. So I do like the comment. I think that it's really important to engage early, ideally in a setting where they don't feel like there's a foreclosed outcome of child protection involvement.
I love that. And that is directly related to the data that you presented. So that's great. Thank you so much. Well, we are at time, so thank you everyone very much. This was a great discussion, and we appreciate everyone coming today for this presentation and for this journal club. Julia, thank you so much for coming in. Super amazing work with a complex data set, really just trying to bring some numbers to something that we see every day. So we really appreciate your work in this space. I'm just going to put a bug in everyone's ears. The next journal club is scheduled for February 27th at 1 p.m. Eastern Standard Time. That invite will be coming out soonish, as soon as I get it out. But please feel free to hold your calendar, and we will see everyone then. Thank you again for coming.
Thank you.
you.
Bye.